I'm editor of the Bucks-Free Press and the Star. I know this isn't a great turnout, and perhaps snow is to blame for part of it. It might be apathy, who knows, but thank you all for coming, appreciate it. Just, we're lucky enough tonight to have two MPs, Steve Baker, MP for Wycombe, and Dr. Phillip Lee, MP for Bracknell, the man behind the super regional hospital plan. Phillip is going to speak for about half an hour about the plan, and then we're going to open it up for questions. Just to explain my involvement, I'm going to chair this forum. I have been, as well as being the editor of Bucks-Free and the Star for many years, I have been chairman of a group called Save Our Hospital Services on and off for about 8 to 9 years. But that doesn't mean our group necessarily backs the regional plan. And I want to make that clear. We are neutral on that. We want to hear more information. We want to see the public reaction. We want to see if it all stacks up. I'm aware there are a number of NHS people here tonight, and thank you for coming very much. Obviously, you'll get if you want to say anything, you're more than welcome to speak. Just before I go any further, can I ask who is actually a genuine member of the public here? Hands up. Oh, excellent. And can I do a straw poll? Right from the beginning, out of you, who in principle, just in broad principle, without committing it, would back Dr. Lee's plan on what you've read?
When you say that, would you like to enlarge on that?
Let's let Philip enlarge.
We'll let Philip. And who is coming with preconceived notion of saying it's not going to work? No, you're all neutral. That is wonderful. Unbiased. That is fantastic. Yeah, without further ado, I'm going to introduce Steve Baker, MP for Wycombe, who's going to say a few words.
Well, can I just add my thanks to all of you for coming, and particularly those who aren't actually being paid extra for being here. So thank you very much indeed for coming. And Steve, a big hand to Steve, because he's done a fantastic job over a long time on hospital services. Will you just join me in thanking him? I really just want to say this, that Philip has worked incredibly hard on this proposal. I know it's heart and soul, as well as mind and experience. It's a very serious and credible contribution to the debate. I don't want to feed back on it until he's introduced it, but it's a pleasure to welcome Philip and to see what he's got to say. I hope you'll take seriously what he says, and that it will be a good contribution to debate. But I will say, it is Philip's idea. There was a little flurry went round with people thinking that this was a new government proposal. It's not a government proposal, it's Philip's proposal. And in that spirit, I hope you'll listen carefully to what he's got to say, and with an open mind, and see what you think. So Philip, with that, thank you very much for coming, and over to you.
Good evening, ladies and gentlemen. This is the fourth meeting of this kind. Sadly, it maybe it is due to the weather, this is the least attended of those 4 meetings, which I think people maybe want to reflect upon in terms of the interest in hospital provision for the area. The last one I did was in Maidenhead with Theresa May, and at that meeting I adopted a more, shall we say, relaxed approach to my presentation. And I came away with a feeling that I perhaps hadn't got over enough of the details in terms of the context in which this proposal that I brought forward last year, which has been readily available for anybody to read on my website since I think last April or May. So there's no excuses if people haven't read it. It is there and it's in the public domain. A few caveats up front. One, I haven't been paid anything additional for doing it. I'm not promising a hospital in my own constituency. It was prepared pretty much in my spare time, in the spare time of my researcher Eva, who's here in front of the camera. And I stress that because I personally think politicians get a bit of a raw deal, and there's a huge amount of lazy cynicism out there. And I can tell you that this has been produced with absolutely no additional financial support, and indeed is a project that I've been thinking of for many a year, prior to even becoming a Member of Parliament. Indeed, I mentioned it before I was selected in Bracknell. It's based upon over a decade of experience in local healthcare provision in this area, both within hospitals and as a GP. I have consulted in excess of 50,000 patients. I can tell you it's 50,000 because I was always a GP locum and I invoiced on the basis of how many patients I saw. So I only have to add up my invoices and I can tell you how many I saw. And as a consequence, and in addition to that as well, my father was born here in High Wycombe, grew up in High Wycombe. My family roots in this town are extensive, and I can trace my family roots back to Radnage in 1750. I now live down on the other side of the river, near Bisham, and yes, I represent a constituency called Bracknell, which is actually represented, which actually has 3 acute NHS trusts serving it, which makes it rather complicated for me in terms of discussing this issue. And secondly, and I would emphasise this again, which is why I'm not being like a typical politician and trying to sort my own manner out. And in fact, this only really broadly applies to the town of Bracknell itself. And indeed, if I was being a typical politician, it would be cited in Bracknell, would it not? But in fact, I'm not doing that, and I've never suggested that it should be cited in Bracknell. I chose Junction 89 in the project that's currently in the public domain because I was conscious of a potential sort of location that could serve a community which I knew and understood quite a lot, and also because I was aware that the financial plight of the trust, the acute trust in East Berkshire, and also the fact that it has been a long-running sore here in Wycombe that it's a hospital isn't really a proper hospital in the true sense of the word, because not all services are offered there and indeed haven't been offered there for many a year. But anyway, as I just want to read you, and apologies for it being a rather dry speech, but I thought I would write a speech for this evening for a change instead of just winging it. So allow me to read this speech, and then I will sort of outline with a bit more detail about the project. Funnily enough, as a politician, I've been misrepresented on a number of occasions already, and I would stress at all that the motive behind all of this is to provide the very best care for over 500,000 people, and that has been my primary motive. My concern is that we continue with the make, do and mend, patch up, put a service here, put a service there approach, which has bedevilled the health economy in this area for many a year, that we're going to end up with services that are just not fit for purpose, and we're all going to suffer as a consequence. Anyway, without further ado, it is a pleasure to be here this evening, and it's a privilege to have an opportunity to speak on this subject. It's a subject that I've long bored medical colleagues about for at least 8 or 9 years. I remember having conversations whilst assisting in operations at Stoke Mandeville about how ludicrous I thought hospital locations in Buckinghamshire and Berkshire were. So it's been long been something I've thought was needed. As I've said already, I have the honour of being a member of Parliament for Bracknell, and I continue to work as a doctor, having recently worked both here in Buckinghamshire and in Berkshire in the last month or so. As I've already said, over the last decade or so, I've treated over 50,000 patients. The majority of those patients actually were probably shared between Aylesbury, Slough, and maybe Aylesbury and Slough is the predominant number of patients I've seen. And as a consequence of having treated and cared for and done my best with those patients, I've referred them, when required, into every hospital that will be mentioned this evening. I've dealt with acute, and I've dealt with chronic, predominantly chronic situations, and I've done a huge number of out-of-hours sessions, primarily because I made the rather odd decision to develop my house and ran out of money, so I had to keep doing out-of-hours sessions repeatedly for about 18 months in order to pay off the debts that I'd accrued. And as a consequence, I know what it's like in the out-of-hours arena, and I know where the patients go, depending upon how sick they are. There have been some changes in that area around acute stroke services at Wycombe in the last couple of years, but I note that it's a service that's on one site, which I think is commendable. It's a pity it's not on 2 sites, in view of the fact it's 2 trusts that are involved in the provision of it, and I think that is actually a classic example of what happens when you try to maintain as many acute sites as we do have. NHS hospitals up and down the country are undoubtedly facing mounting financial, workforce and demographic pressures. The stark reality is that healthcare provision in the future will require a real need for consolidation of acute and emergency services in fewer locations and an increase in the provision of chronic care in the community through locally based clinics and facilities. This is not a political choice, but rather a clinically driven reality, and I stress that at no point in this process have I mentioned party politics. If you think this would be any different under a Labour government, you're kidding yourselves. It's going to be the same whichever government you have. It is widely believed among the medical profession that the reconfiguration of hospital services can provide a powerful means of improving quality in an environment where money and skilled healthcare workers are scarce. In some places, reconfiguration and changes to hospital services are already a necessity, not an option. Indeed, Northumberland Healthcare kindly came down to see me in Westminster recently, took me out to lunch to congratulate me on my plan. It's taken them 14 years to consolidate their acute and emergency services onto one site, and they now have successfully dined on the A1 just north of Newcastle. The reality is that Thames Valley is one of those regions where reconfiguration, I believe, is required, which is why I undertook the proposal which I published last year. In it, I called for a consolidated, so-called super hospital. I'm not particularly keen with that use of the word, but it's one that seems to stick, down Junction 89. Because I believe the Royal Thames Valley Hospital, as it may be called, at this location would bring about crucial advantages in terms of the use of existing transport infrastructure, thereby allowing service to the greatest possible size of population within easy reach of their homes. This model has a multitude of benefits, which include economies of scale, sharing of medical information, sharing of manpower, and is supported by the great majority of medical organisations, such as the King's Fund, the Royal College of Surgeons, the Royal College of Physicians, and indeed the Royal College of Paediatricians, the president of which came to see me the other day to pat me on the back and say, keep at it. I believe that it is the key to saving the provision of top quality NHS acute care in the medium to longer term. Nevertheless, I feel a lack of the strategic leadership required to lead and deliver change, and that does apply to Whitehall and Westminster. Major stumbling blocks in many hospital reconfigurations are public concern, understandably, vested interests, of which there are numerous in the National Health Service, and political opposition. Politicians will have to make decisions on the basis of quality, safety and efficiency, whilst also retaining strong public engagement in local decision making, that's for sure. And that's why I'm holding these regular meetings. As I said, this is my fourth, and my next one is in Slough next month. In my speech this evening, I want to first set the context and talk about the current difficulties our healthcare system will be facing in the future, and then I will discuss the future drivers of hospital reconfiguration, and then conclude with some recommendations for improvements. The context: in the past 50 years, according to the King's Fund, published in 2011, the number of acute hospitals was reduced by 85%, and the number of sites in which elements of highly specialist care is delivered is reduced even further. In England, general acute care is now delivered in just over 200 hospitals, and at the same time, the average size of the hospital has grown from 68 beds in 1962, not long before Wycombe General was built, to just over 400 beds. The acute trust is the average for an acute trust in this country now is just over 580 beds. Those figures are up to 2011. To give you a sense of where we are, the JRH is 805 beds, Stoke Mandeville is 479, Wexham Park is 450, Wycombe General is 250, and the Royal Berkshire is 721. So as you see, Stoke, Wexham and Wycombe are all actually under the average acute trust size for number of beds. These changes reflect developments in medical practice. Advances in medicine and surgery have driven clinical staff and equipment to become more specialised. The skilled specialist staff are scarce and budgets are limited. Services have been centralised into fewer, larger sites in order to ensure patients are cared for by staff with the necessary skills and supporting specialist equipment. In addition, there has been decreasing reliance on bed rest as part of treatment. For example, most routine surgery is now undertaken as day surgery. The average length of stay in hospital is currently just less than 6 days, and 80% of all patients have stays of less than 3 days. Having surveyed both NHS trusts and the public and service change, the Foundation Trust Network found that 90%, 90, of NHS trusts said that a major change, hospital merger, closure or changing the way services are provided, was necessary in their area in the next 2 years. Critically, 78% of trusts, 7-8, felt that a reconfiguration in their area would lead to maintained or improved patient outcomes, which would not be possible if the change did not take place. Of those NHS trusts indicating that the reconfiguration would be necessary, 35% felt that there was a consensus locally about how this should take place. Local councillors were felt to be a barrier to service change in 49% of cases. NHS trusts were viewed as a barrier in 48% of cases, and MPs were viewed as a barrier in 40% of cases. Finally, market research organisation ICM's polling of the public shows conflicting views. 4 out of 10 people initially stated they would prefer to be treated locally, but when asked to rank the importance of having services close to home versus accessing specialist care when being treated for a serious condition, over half said that it is most important to be treated in a unit that specialised in their treatment area. That number rises to 60% if the respondent is talking about a loved one receiving the treatment rather than themselves. 3 in 10 said it was most important to have a hospital close to where they lived in this case, suggesting that whilst people value the convenience and accessibility of local care, ultimately access to specialist expertise matters more when a serious condition is involved. Now, future drivers of hospital reconfiguration. Demographic changes, the shifting burden of disease, all of this will require a fundamental shift from the hospital as the core focus of service to the community, to provide elective care and minor treatments from the community level, and all major surgery and acute care from a central hub hospital. Emphasis on hub and spoke. A hub hospital at which you have all the serious stuff and acute emergencies, and then a series of spokes out to community hospitals and clinics providing chronic care and rehabilitation services. The challenge is to try and arrive at a configuration that optimises all the elements of quality, workforce, cost and access. And there always will be trade-offs, and I will just interject then that I'm fully aware of the fact that I've just got to take one area of England in isolation of all the other areas. Don't think that I haven't tried to persuade the Department of Health and various ministers of the need for a national plan so that we could actually sit down and decide, right, the hospitals need to be here, on motorways or on dual carriageways, relative to the demographics of the area. Unfortunately, and I keep trying, there's nobody in the Department of Health working on this, and as a consequence I have to do them almost rather daft thing of saying, right, okay, I'm just going to take off this piece of land, which funnily enough, and you don't need to be particularly informed to know that this would have knock-on effects against other hospitals. You don't need to commission a report and spend money on commissioning a report to conclude the bleeding obvious. Of course it's going to have a knock-on effect. I recognise that and recognise that from the outset. I've never been at all tried to hide that, but as far as I'm concerned, the current situation with the number of acute sites is not sustainable, so I had to choose somewhere where to locate it. And by definition, that's obviously going to upset various acute trusts and other vested interests. Anyway, with regards to better quality of care, quality considerations include access to highly trained professionals in all disciplines, compliance with clinical guidelines, access to diagnostic technologies and other support services, as well as strong clinical governance. More recently, there has been pressure on trusts to meet challenging funding needs, which is putting greater emphasis upon operational systems and environments to work together to meet the targets and improve patient safety in acute care settings. We only have to look at the Staffordshire to see the challenges and what can go wrong. There are also interdependencies between services. For example, withdrawal of paediatric services can threaten obstetric services, which rely upon paediatricians to provide care for the newborn child. Take a look at the current service provision in this area. There is wide variation in the quality of care delivered by NHS hospitals. Reconfiguring services can be a powerful means of addressing this variation. As often cited, successful example is in London. It has been estimated that the recent reconfiguration of stroke services has saved more than 400 lives a year. This is through the establishment of stroke networks that have concentrated specialist stroke expertise in diagnostics and fewer units, while retaining local access to stroke rehabilitation services in local hospitals, i.e. you have your stroke acute at your hub, and then you have your rehabilitation post your stroke in your community. Other examples include vascular surgery, where the mortality rate is lower in high-volume hospitals than low-volume hospitals. Reference Naylor et al. 2012, and paediatric heart surgery, where there are plans to cut the number of hospitals undertaking surgery to improve outcomes. With regards to vascular surgery, it's well documented, front page of the Telegraph. My father had a vascular operation last year. It wasn't emergency, it was urgent for abdominal aortic aneurysm. I was fortunate, I have knowledge, I'm a medic, and I decided that he should have his operation elsewhere. Indeed, he ended up having an operation that is not available, as far as I'm aware, in this region. It is an example of where if you consolidate and you put everyone on the same side and you attract consultants or particular specialists in particular fields, you can end up providing those operations nearer than he had to go, because he had to go to London to have this operation. It's all above board, it's no different, you get your GP to refer you where you want to go. What I would suggest to you is that it's not right, and it's not necessarily morally right, but it was only because I knew that I got my father to do into that surgeon. I want that surgeon and people of that quality and experience and expertise to be available to all in this country. It's estimated that stroke mortality rates across acute hospital sites across England would be 2,117 fewer deaths per year from stroke in England with increased ambulance services to those specialist centres. This clearly demonstrates that centralisation of stroke and trauma centres would benefit a larger proportion of the population and would reduce mortality rates and thereby improve the quality of care. Reference Spurgeon et al. 2010. Alongside these changes, there is a need to shift the location of care for older people who do not require specialist care in a hospital setting. The Royal College of Physicians estimates that almost 2/3 of people admitted to hospital are over 65. People over 85 account for 25% of bed days. As we have noted, older people make up the majority of patients in hospital beds, and yet many could be cared for elsewhere if appropriate facilities were available. End-of-life care illustrates the inappropriate use of hospitals. Notwithstanding the recent increase in the proportion of people dying at home, many still die in hospital, although they